Hello, everybody. Great to have you back. I know that was a very quick break, but we've got a very exciting program for the rest of the day. We're now going to jump into general session part 2, and welcome. I want to take just a brief minute to reintroduce the moderator for this session, and that is Dr. Laura Lambert. Dr. Lambert is the chair of the ACPMP Medical Advisory Board and a longtime and instrumental supporter of ACPMP. I reach out to her with a question at any time, and she's just incredibly responsive and helpful and smart. Dr. Lambert's a professor of surgery at the University of Utah. She's the director of the peritoneal malignancy program at the Huntsman Cancer Institute and the program director for the general surgery residency. She is also board certified in hospice and palliative medicine and is just an incredible human being. So thank you very much, Dr. Lambert.
Thank you, Deborah. It's great to be here, and welcome everybody to the second session of the ACPMP symposium. And it is my privilege to introduce the first speaker of this session. It's Dr. Constance Vatanopoulos, and he is professor of surgery at Wake Forest University and the founding director of the Wake Forest Organoid Research Center, also known as W-Force, which I think is awesome. Speaking of analogies, he is a recognized expert surgeon and thought leader in the management of peritoneal surface malignancies with over 200 publications, NIH-funded research, and numerous presentations. I really look forward to hear, as this session is really focusing on the future and it's expanding our treatment of appendiceal cancers and tumors. So, Dr. V.
Well, thank you very much for the privilege of the presentation. This is our, let me see, give me 1 second. Yes, this is our funding. We have 2 R1 grants. One of them is dedicated to appendiceal cancer. We also receive funding from ACPMP, the Mesothelioma Research Foundation, and of course the Wake Forest Cancer Center. So allow me a few slides because we need to establish a common ground of how to have a common understanding of what an organoid is and where do we fit. Organoids fit in the precision medicine. So today, if we talk about precision medicine, what we have in mind is sequencing. You send a person the tumor, you get a list of mutations, and you correlate these mutations with possible treatment. The problem with that concept is that changes the outcome only 11%, changes the plan 11% of the time, and changes the outcome for the patient only 3% of the time. And what better depicts this problem is this data from Memorial, where they almost offered sequencing to everybody. Out of close to 6,000 specimens, only 7.5% of them were predictive of a clinical benefit. So what we say with the organoids is it is great to know what type of mutation you have, but it's also very important to know what type of drug or immunotherapy is working for the specific tumor. So what we do is we take the tumor, we dissociate the tumor, we essentially melt the tumor and take all the cells out, and take these cells. We are not sorting them. We take the entire tumors, the entire cells that the tumor is made of, and we drop them in a hydrogel. We do 0 cell expansion, and because we do 0 cell expansion, this is why we have the ability to generate results in 5 to 10 days in close to 80 and probably now close to 90% of the patients. So how does it work in real life? This is a patient with advanced peritoneal disease. The entire abdomen is occupied with a tumor. We take a piece of a tumor, and what you see here is the first ever mesothelioma organoid that was created outside the body. And then a week later, we take this tumor and we test it with several drugs. And what you see here is you see different drug combinations on the left column, and you see how much of the tumor stays alive on the right column. And red means dead cells, and green means live cells. So for the specific individual, the best treatment is the one at the bottom, where only 11.8% of the tumor stays alive after treatment. And tumor evolves, and we have the opportunity with the organoids to biopsy the tumor when it comes back. This is a patient that has a recurrence on the abdominal wall where the blue arrow is. And you take a piece of a tumor, you grow it again, you test it, and you see what has changed. Does it respond to the same fashion? Do you have a different response? What's the best drug in at that time of the tumor evolution? So we do also what we call a tumor on a chip. I call it the HIPEC of the organoid. The organoids are growing within the small wells in the center of the plate. We have cannulas that come in and out through the circuit. And it is a live system. You can check what is, how the tumor is responding with treatment, what is happening real time with the tumor. And of course, one of the questions that came to us is, okay, chemotherapy is like a chemical, it's like a poison. You drop it over the tumor and you find out if it is working or not. What about immunotherapy? Immunotherapy, it's different because it requires an intact immune system within the organoid to be activated. So for you to see if there is a response or not. The problem with the organoids is that they don't have an immune system. The tumor does not have an immune system besides some few TILs, tumor-infiltrating lymphocytes that may be or may not be present in the tumor. So we were discussing one day with a patient, and he, around 2016, 2017, and they asked us the question, can you predict immunotherapy response? So it came to us that if we take the lymph node from the patient, and the lymph node contains 80% of your own immune system, and you mix the lymph node or any other immune component of the patient with the tumor, you develop what we call an immune competent organoid. And then you check the immunotherapy on that structure. And what you see here is that on the lower panel, you have tumor only without an immune system. And when you hit the tumor with immunotherapy, Pembro and Nivo, nothing happens. The tumor stays green because there is no immune system to be activated. When you add the immune system on the upper panel, then what happens when you give immunotherapy, the immunotherapy is getting activated by the immune system is getting activated by the immunotherapy, and the immune system is killing the tumor within the organoid. And when we examine that concept in real tumors from melanoma patients, we were able to correlate at 85%. It was a small sample, only 7 patients, but 6 out of 7 times we were able to say if the immunotherapy was behaving in the same way that it was behaving in the patient. Do you have any other correlating data? The best correlation data with the patient response in the literature are coming from Dr. Vlachogiannis in Science, published in 2018, where out of 71 patients enrolled in prospective randomized trials, the positive predictive value was 88%, and the negative predictive value was 100%. That means that when the organoid was responding, the patient was responding 88% of the time to treatment. And when the organoid was not responding, the patient was never responded. And this 100% negative predictive value is very important. And I think that this is where the organoids are heading to. They are not going to be they are going to be more prominent in determining what treatment is not going to be effective, sparing the patient from a treatment that will buy him complications only and cost without any survival benefit. So how do I apply all of that in a situation like this one? This is an appendiceal cancer, and unfortunately we see neglected stages of appendiceal cancer quite often. This is now we have the ability to generate these tumors, to reconstruct them outside the body. And this is an appendiceal cancer organoid. Green is alive appendiceal cancer cells. And after we develop that ability, we start doing chemosensitivities. And what you see here on the right side is that when we tested low-grade appendiceal cancers, including adenocarcinomas with chemotherapy, nothing was working. Nothing was able to kill these cells. On the left side, you see high-grade appendiceal cancers that were responding to chemotherapy, but the response was like patient-dependent and it was also tumor-dependent. And what about immunotherapy? It seems that when you start testing appendiceal cancers with immunotherapy, less than 20% of them there is a response to immunotherapy that is also patient-dependent and drug-dependent. What about chemotherapy itself? You grow the organoid, you test it with the HIPEC, and what you see in the brackets is how much appendiceal cancer stays alive after 2 hours of HIPEC with mitomycin C at 40 milligrams. So you see that out of 1 millimeter of tumor, appendiceal tumor, still 2 hours later, you have 18% of the tumors alive under optimal conditions of perfusion. And if you try to do the same HIPEC with oxaliplatin at 460, then close to 50% of the tumor stays alive. And for high grade, if you do mitomycin C, 28% of the cells stay alive. So mitomycin C, at least at the organoid level, is a better option than oxaliplatin. And you can do the same thing for colon cancer. When you treat the colon cancer organoid with mitomycin C, 31% of the cells stay alive. If you do the protein G7 regimen, more than 50% of the cells stay alive. So what about hyperthermia itself? Because HIPEC has two components. One is a chemotherapy and the other is a heat. So should we give hyperthermia to every single patient? Well, the answer is definitely not, because many of the tumors do not respond to heat. I mean, they have mechanisms like heat shock proteins or a total array of mechanisms that they won't let them respond to chemotherapy. So for the brackets, the patients that are in the brackets, adding or not adding chemotherapy, heat in the HIPEC does not really augment the potential of chemotherapy. And from that slide, keep in mind that mitomycin C works often without hyperthermia too. So why all of that are important? It is important because we can take the tumor and check what concentration of drugs work at the systemic level, at systemic concentrations, and what is the effect of the same drug for intraperitoneal concentrations. And you see here that for the same patient, when you try on the left side, oxaliplatin is a very poor choice for systemic concentrations. But when you take the same drug at the intraperitoneal concentrations with heat, with hyperthermia, well, that becomes a very good option for the patient. So why do we fail? This is what you see here is like what we call an omental cake. An omental cake is like the omentum of the patient becomes totally infiltrated by the tumor. It becomes like a plaque. We fail because when you see something like that, number one, the patient waited too long. And when back in time we were saying, well, I cannot really do anything because you were waiting too long, we can very well establish what that too long means. It means that that tumor is not one single population of cells. There are many, many different cells within the same block of tumor. And this is what you see in this slide here. It is what we call clonality. So the tumor started as blue. The genes of this tumor changed. The expression of it changed, the sequencing changed. And then it became yellow, it went to the mesentery. It became gray, it went to the liver. It became pink, and it became also green, it went to the pelvis. So what I'm trying to say is that within this specific patient, you have 5 different clones. And all these clones have different sequencing and how that sequencing is playing into treatment. So the things become more complicated when we try to create an appendiceal cancer cell line. and that was supported 100% by the ACPMP Foundation. Out of a single piece of tumor from the omentum, a part of the omentum, we generated 8 appendiceal cancer cell lines, all of them with different sequencing profiles. And what is the effect of all this tumor evolution within the patient? We took tumors from the same patient that were in different sites, from the ovary, from the appendix, from the left diaphragm, and from the liver capsule. We grew organoids from each one of them. We treated them under the same conditions, with the same drugs, and every piece of tumor coming from different areas in the abdomen were responding differently. So what will happen if you give a patient 3 to 6 months of chemotherapy is that anything that is susceptible will die, and any cells that do not respond will take over. And the same problem is not only for appendiceal or colon, it's for mesothelioma. What you see here is a mesothelioma, a biphasic mesothelioma. Essentially, is a tumor that has 2 components, one epithelioid that behaves well, and one sarcomatoid that doesn't behave well. And when you treat the epithelioid with chemotherapy, you see on the left side, everything is okay. But when you treat the sarcomatoid, the tumor does not respond. And the patient, the survival of the patient, unfortunately, depends on the tumor that they do not respond. So, if we want to approach this problem, the problem of clonality, we need to have some information. And the information is, we need to know how many clones exist within the patient. We need to know what is the relative volume of each clone within the patient. Is it 80% clone A, 20% clone B? What is that relative volumetrics of the cancer? We need to see, we need to know what is the virulence of each one of these clones? How fast do they multiply? Which one should you treat first? And then you need to find out what is the individual response of the clone, of each clone, to drugs. And unfortunately today, we don't really have the technology to do that. So the only thing that can identify all the clones at the same time, and not always, is our immune system, is our own T cells. So we came with this idea to create what we call the organoid infiltrating lymphocytes. What we do is we take the tumor, we mix the tumor with the lymph node of the patient, and the lymph node of the patient contains antigen-presenting cells. The antigen-presenting cells are those who expose the antigens for the T cells to learn how to recognize them. So what we are doing then is, we take the cells, we circulate them through this device, through this microfluidic device, and then up to 7 days later, 4 to 7 days later, we generate the oils, the organoid infiltrating lymphocytes, and we drop them against the tumor to see if they are killing them. And what's happening is that we also check them against the TILs, the tumor infiltrating lymphocytes. What you see here in the center is how TILs perform after you probe them, and how oils perform after you probe them. And the oils perform very robustly, while the TILs are like kind of puny. And I will show you how that cell behaves against the tumor of the patient. So here you see a video that is the center here. You have the tumor. The small round things are the T cells that we have trained against the tumor. And this is happening over 18 hours. So the green color you will see here is the effect of the T cells against the tumor. It means apoptosis. Apoptosis is when the T cells are killing the tumor. I really don't know how to play that. I will try enter. And here it is. So you see that the T cells of the patient surrounding the tumor like piranhas and eating it up. So the green color is the death of the tumor itself. And this is happening. And if you do the same thing, adding immunotherapy, the intensity of the green color becomes much more prominent. So what is the role of organoids in peritoneal disease? I think we can use organoids to complement the concept of prospective randomized trials and animal models. We can study the patient own tumor timeline, how it changes. We can identify non-responders. We can give industry focus on new drugs. And we can use organoids as an avatar for immunotherapy applications. And with that, I will conclude. This is an effort for many, many different individuals. You can find all of us at our website. Thank you for your attention, and I'm going to be happy to answer any questions.
Great. Thank you, Dr. Vatanopoulos, and thank you for sharing the complexity of the challenge that we're facing here in treating these, and also the potential utility of organoids, and for all your work in this space and really driving this frontier forward. Thank you very much. Our next speaker is Dr. Mustafa Raouf. Unfortunately, I believe Dr. Raouf may be tied up in the operating room, but fortunately, he provided us with a pre-recorded message. So Dr. Raouf is assistant professor in the Department of Surgery and the Department of Cancer Genetics and Epigenetics at the City of Hope. He is the principal investigator for the U.S. PIPEC trial in gastrointestinal cancers, including appendiceal cancer, and he is going to update us today on the role of PIPEC in the management of appendiceal cancer. Do we have that footage?
Hey, Jim, can you share this? It's password protected. I can't get into it.
Let me see if I can. Bear with me.
Let me try my other laptop. Give me 1 second. I think I have it open on that one. Let's try it.
Well, maybe while they're troubleshooting that, we could do a question. The one question that has come up in the chat, or the question and answer, is in the case of second cytoreduction and surgery.
So today I'm going to be
we'll go back to Dr. Raouf.
Two aspects.
You may need to turn up your volume to hear it.
Thank you to the ACPMP for the invitation to share the US PIPEC collaborators.
So today I'm going to be talking about two aspects. One is the new and novel therapies for peritoneal surface malignancies, and I'll focus specifically on PIPEC. And then I will also discuss the current open trials and how and which patients need to be accrued to those trials. We have learned a great deal of experience has contributed to our understanding and progress in treatment of peritoneal metastases from appendix cancer. In general, we understand that peritoneal metastases have a poor prognosis for many patients, especially the ones with high-grade appendiceal cancers. There's unique quality of life considerations as the disease gets worse. Patients can develop bowel obstruction, obstructive uropathy. They can develop ascites, and they can be quite symptomatic. We know that cytoreductive surgery improves survival for many of the diseases that spread to the peritoneum. And we've done a good job over the last 10-20 years to reduce the morbidity and mortality from these operations, but they continue to be significant for the patients. And we've also learned a lot about sequencing treatments as to when to give chemotherapy and when to take patients to surgery. But there are many challenges that remain. Many patients are not candidates for curative intent surgery, and many patients will recur after cytoreductive surgery. Systemic therapies and even the newer targeted immune therapies have not shown their promise in appendiceal cancers. With big surgeries, there's a big trade-off in terms of quality of life, and we're constantly having to balance this for patients, and many of the patients suffering from this disease are well aware of those trade-offs. And regional therapies carry a significant promise, but they have to be validated in prospective clinical trials, and we have to personalize treatments based on patients' tumor makeup, and this will be more important as newer therapies come to light. So this is how I see the future of peritoneal surface malignancies. This includes peritoneal metastases from appendix cancer. On the top is personalization, where we take the patient's tumor and we're able to grow it in a petri dish and also look at their molecular makeup and figure out the best treatment. We need to develop new novel therapies, and these include biologics, nanotherapeutics, viruses, cell-based therapies, and others. And then we have to focus on enhanced drug delivery methods, and PIPEC is one such method. So what is PIPEC? So PIPEC is a minimally invasive technique. It's performed laparoscopically, and it's considered ambulatory surgery. Most patients will stay overnight and then go home the next day. In this particular instance, high-dose chemotherapy is delivered directly into the abdominal cavity. So you think of it as a way to fumigate the abdomen. And the theoretical advantage is that when chemotherapy is administered under pressure, there's more tumor penetration than you would expect from just instilling as in HIPEC or IP, normothermic IP chemotherapy. There's also a more direct contact of treatment and tumor than you would expect if you were to give the treatment intravenously. This concept was popularized in Europe, specifically in Germany, and it created a lot of buzz when a 2019 Lancet Oncology paper amalgamated that experience in Europe and demonstrated that a significant majority of patients in chemorefractory settings were having clinical responses, and I'll get back to that a little bit. But more importantly, this was a safe intervention compared to many of the systemic therapies where systemic chemotherapies where the severe adverse event rates are 30%. In this particular context, they were 12 to 15%. There's some of the early porcine pig studies, essentially comparing HIPEC to PIPEC, and it was learned that from these studies that when you give PIPEC, you get more homogeneous and distribution as well as a higher yield. For the amount of chemo that's given, more is deposited onto the peritoneal lining as well as tumors. So what is PIPEC? So how is it set up? So we use an injector. On the screen left, you can see the chemotherapies in the syringes. This is an automated injector. It's remotely activated. It's actually off-label use of the injector that is used for CT scan contrast injections. And the nebulizer device, which is placed in one of the laparoscopic trocars, looks like a pen with a little tiny nozzle at the end of it. And as the chemotherapy is pushed by the injector through this nozzle, it becomes aerosolized to about 3 micron particle size and with an angle of aerosolization about 60 to 70 degrees. This is the laparoscopic setup. You can see in the patient's abdomen there are several ports that are placed, and initially we will perform a thorough assessment, calculate the peritoneal cancer index, as well as take biopsies, take out the ascites, and document the volume. And we use balloon trocars to avoid leakage of chemotherapy or aerosol into the operating room environment. And on the top left, the big arrow demonstrates the capnopen or the device sitting in the trocar, and the camera is fixed on a camera stand. Everybody leaves the operating room and the patient's remotely monitored. The injector has the chemotherapy here, and everybody can watch the screen. The anesthesiologist can monitor the patient as well, and the chemotherapy is then administered, and it looks like a snowstorm in the abdomen. So a number of trials across the world are being conducted. This is a list of phase 2 trials that are ongoing, this is as of March of 2022. We started our trial in the US in August 2020, and initially this was a 2-arm trial. Arm 1 focused on patients with ovarian, uterine, and gastric cancer, and the second arm focused on colorectal and appendiceal cancer patients. The arms were separated based on the type of chemotherapy that is being used, and we essentially used the same chemotherapy that was thought to be in Europe to be of benefit, at least initially. And so the goal of the study was to confirm the safety and efficacy results from the European centers. And the way we did that was by measuring dose-limiting toxicities in the first 6 weeks after BiPAC administration. So Arm 1 is almost completed accrual. I think there's one more slot there, and Arm 2 has completed accrual, and I'll share the data with you for Arm 2. So a total of 12 patients were accrued to Arm 2, which is the colorectal appendiceal arm. You can see 4 patients had appendiceal cancer, 8 patients had colorectal cancers, and the rest of the demographic distribution is listed. Important to note is that these patients are highly chemotherapy refractory. Most of them, almost all of them, were refractory to 2 lines of systemic chemotherapy. And in this cohort of patients, we found that performing BiPAC was feasible. Half of the patients completed at least 3 treatments, and 58% completed 2 treatments. The most common reason, or actually the only reason for discontinuation of BiPAC, was disease progression, as can be expected in a chemotherapy refractory cohort of patients. Importantly, we did not see any surgical complication. We did not see any dose-limiting toxicity, suggesting that the approach was safe. We did see some grade 3 toxicities, and the overall severe adverse event rate for grade 3 toxicities was about 2%, about 8%. So this is the early efficacy results. In our cohort of 12 patients, 2 underwent optimal cytoreduction and HIPEC. This was at the decision of outside non-trial related physicians, and so it was independently taken. But nonetheless, in terms of radiographic response, we had 5 patients, 45% had stable disease, 45% had progression of disease on radiographic imaging, and 1 patient had non-measurable disease. When you look at the laparoscopic assessment, you find that 45% had decrease in their PCI, 9% had, or 1 patient had stable PCI, and 5 patients, or 45%, had increase in PCI or could only get 1 BiPAC because of disease progression. Histologically, 58% of patients had response or stable disease as their best response. Now, when we try to correlate this change in PCI with radiographic response, we find that most patients who had stable disease on their CT scans were actually having declining PCIs based on laparoscopic assessment, as you can see. One of the challenges with this trial and any trial of peritoneal metastases is how do you assess response? And so we measured it in 3 ways, which is laparoscopic, radiographic, as well as histologic. But these measurements are somewhat limited, and each of them has their benefits and disadvantages. Laparoscopic assessment is limited because it's sometimes hard to tell if there's a tumor or scar tissue. If the response makes the tumor less thick, it's not clear if the PCI will be decreased as well, because the PCI is based on the size of the lesion. So laparoscopic responses are assessment is limited. Similarly, histologic grading is somewhat limited because many patients who have been treated with chemotherapy have evidence of some sort of response at baseline, and there's a lot of heterogeneity with it. And so in this particular analysis, we're looking at whether or not there's correlation between radiographic response and histologic response. And as you can see, the median PRGS, which is the median response of each of the 4 biopsies that we take at the time of each BiPAC, we calculate a median and see if the change actually correlates with radiographic findings, and we do it in another way with the mean PRGS, and both panel A and B demonstrate that there's actually no correlation with radiographic assessment, and we show it in another way with correlation between laparoscopic response and histologic response, and again there's no correlation, suggesting that laparoscopic and histologic assessment response is severely limited. So what do? we look at survival. So survival has been the gold standard of assessing efficacy of any treatment. And so in this cohort of patients, you can see the swimmer's plot where each row demonstrates each patient, and you can see their journey through the trial. Half of the patients had progression of disease, and that's marked with a circle, and the other half had stable disease, and meaning the disease was not progressing. And when you look at survival, the survival data initially at least appear encouraging, and I would put that into context by comparing with third-line systemic chemotherapy. This is kind of the cohort where in which the trial was conducted in. So you can see the US PIPAC Arm 2 trial, the median overall survival was 12 months. And if you compare that to the median survival for third-line chemotherapy with TAS-102 or regorafenib, these are approved therapies for colorectal cancer, it's 7 months and 6.4 months, and progression-free survival was similarly better. So in other words, I think the treatment seems to be effective, but it just needs to be proven in a randomized trial. This sort of comparison is fraught with challenges because the two populations are very different still, and so this needs to be studied further. So what's next? So I think for the oxaliplatin PIPAC, we are looking into a trial design that would incorporate quality of life measurements, but I want to talk about this trial, which is currently open, as it'll be of interest to the audience. So this is a trial of patients with colorectal or appendiceal peritoneal metastases with peritoneum limited disease. Patients could have had prior cytoreduction, but there should be enough room to perform laparoscopy and fumigate the abdomen with chemotherapy. Patients who've had extensive adhesions may not be eligible for this trial. In this particular trial, patients should have been treated with at least 4 months of chemotherapy, which is standard of care. And the idea is to do some induction chemotherapy to exclude patients who have rapidly progressive disease for which we don't think regional therapy approach makes sense. So after those patients have met eligibility criteria, they should have good performance status and no evidence of bowel obstruction. We give them mitomycin C PIPAC. So mitomycin C is a drug that's used in HIPAC across US and has efficacy that has been demonstrated in HIPAC studies. And so we think it would be an active agent in the peritoneum when delivered with PIPAC. Here we combine mitomycin C with IV FOLFIRI, which is standard of care chemotherapy, and the PIPAC is given every 6 weeks, and the chemotherapy is given in between at week 2 and 4, and so on. And the goal of the trial is to identify the optimal dose of mitomycin C, so it is a dose escalation trial. So far we have completed dose level 2, and it appears to be safe, and so we're expanding to dose level 3. The idea is to assess the dose-limiting toxicity similar to the other trial, and we will be looking at markers for efficacy. In addition, we are collecting correlative studies for assessment of molecular assessment of which patients actually respond to treatment versus not. And the patients will get a laparoscopy at week 18 to see if they've had enough cytoreduction, if they have enough downstaging to allow for cytoreductive surgery. Patients who are candidates for cytoreductive surgery will be excluded from this trial because those patients should undergo cytoreductive surgery if feasible, unless they have comorbid conditions or other reasons that preclude cytoreduction. So this is, just like the previous trial, is a part of a US PIPAC collaborative, and Northwell and Mayo Clinic have been partners with City of Hope and have been accruing patients to these studies as well. So this is open to accrual. We expanded this concept in the biliary tract cancer patient population. So in this particular context, patients who have peritoneum limited disease will be getting standard of care gemcitabine cisplatin, and then they get Abraxane PIPAC. So Abraxane, for those of you who are not aware, is an albumin-bound paclitaxel. It's a nanoparticle. So we're testing the concept of delivering nanoparticle PIPAC and assessing its efficacy. So this is also open to accrual. It's funded by Phase 1 Foundation. So what else can we do with PIPEC? I think there are many therapies that could be administered through PIPEC and have been in some preclinical models. Some of the studies have been done in humans, and some of the studies are being planned. So I think there's a lot more that can be done. I think the advantage of PIPEC is that it allows for uniform homogeneous distribution of a small volume of drug throughout the peritoneal cavity, and it can be done repeatedly. So with that, I'll conclude. This is the peritoneal surface oncology team at City of Hope. The picture in the bottom left is Dr. Dellinger and I operating, and Dr. Dellinger and I have been co-PIs for the US PIPEC trial. And Dr. Dellinger is a gynecologic oncologist and runs everything related to the ovarian and gynecologic cancer population. And then I want to mention our collaborators from Northwell, Dr. Valian, Dr. Di Peralta, and from Mayo Clinic, Dr. Amit Murchia, without whose support we wouldn't be able to learn and make progress. So with that, I'm going to end. Thank you.
Great. Well, again, unfortunately, we didn't get to hear from Dr. Raouf in person. There were some questions in the Q&A regarding PIPEC, and really at this point, as you can hear, it's very early days for PIPEC. We're still sort of figuring out the optimum use of the technology as well as the chemotherapy agents, and so it's hard to answer specific questions about specific cancers, and we're not even sure about the impact on people's quality of life and even potential complications after the surgery. So stay tuned, more to come, and thankfully we're starting to see some clinical trials in that arena. Next up, we have Dr. Vadaya, I hope I said that correctly, from the Cleveland Clinic. He is a multi-organ transplant surgeon with a special interest in intestinal and multi-visceral transplantation, techniques for the cure of slow-growing abdominal malignancies for which conventional therapy has failed. He was a consultant transplant surgeon at the University of Oxford for more than a decade and had significant experience with transplantation for pseudomyxoma there. He then moved to India, where he started the Center of Liver Disease and Transplantation, and he is now the director of intestinal transplantation at the Cleveland Clinic, where he led his team to perform the world's first true multivisceral transplant for PMP. So Dr. V, thank you so much for being with us. I know this is, again, another area of significant interest for this community.
Well, thank you very much indeed for having me on this symposium. Can you guys hear me okay?
Yes, yep, can hear you.
Okay, thanks. So I'm just trying to get hold of how to change my slides.
If you just click on the slides, you should have control, and you should be able to advance as you normally would.
Okay, here we go. Yeah. There we go. Thank you. Thanks for that. So the real question is there a role for a combined intestine and abdominal wall transplant in patients with PMP of appendicular origin that have failed all conventional therapy? That's the real question. And that question, we tried to answer that question about 10 years ago in Oxford. And the little story behind that with a very prominent rugby player came up to me, researched me at Oxford, and came up to me and said, I've got pseudomyxoma, and is there a chance for a transplant option? So I really took him on in terms of his case and discussed this with two of the peritoneal malignancy centers in the UK at that time. One was at Basingstoke at the Pelican Centre with Tom Cecil and Brendan Moran, and the other one was up in Manchester at Christie's. So getting all their thoughts together, we then put up a protocol to be able to transplant these patients under an IRB at the Oxford University, and that's how we did the first one. But we've learned a lot of lessons after that, and we've come about with the indications that it perhaps to begin with needs to be of appendicular origin. It has to have had failed all conventional therapy, including debulking, resurgery, HIPEC, PIPEC, and what have you. Some patients present with obstructed bowel with a very central disease, where the peritoneal lining's been taken out, but the central disease is a problem because it would lead to massive resection of bowel. The disease has to be limited to the abdomen. We are in that phase of our application of transplant oncology to this pathology in a very early stage, and therefore we are being cautious. We want to be sure that there's no disease elsewhere. There were some concerns about hepatic hilar infiltration when we were in Oxford, because there was no way we could have got a liver included into the graft in the UK, because there was a paucity of organs and what have you. So were we able to clear the hepatic hilar infiltration enough to produce a relatively robust debulking of disease or not? That was a thought process. When I say renal involvement, it was a relative contraindication. We're not talking about kidney involvement. We're talking about the involvement of the ureters. These are the channels transferring urine from the kidney to the bladder. It's in the retroperitoneal space. Usually, from our experience, the low-grade appendiceal cancers do not get into the retroperitoneal space, and there's definitely a preserved plane, so to speak, at that place. We can lift everything off. And of course, at that time when we started off, we said patients needed to be on TPN, which is not true anymore. The whole process and the algorithms have advanced, and you really do not have to be on TPN in the UK at least. The Oxford experience, going back, started in 2013, 20 cases were transplanted. So very, very small experience. All of them had what's called as a modified multivisceral transplant. And in Oxford, they did have abdominal wall transplants in addition to their abdominal organs. So when I say modified multivisceral, it is a terminology in our transplant world that includes the stomach, the pancreatic complex, the small intestine, and plus minus the colon. It does not include the liver. So going on to the Oxford experience, we had a median follow-up of 48 months. We had 3 deaths. One was graft-versus-host disease. In fact, this was the first case that I did. This was the pivotal case that changed the outlook for pseudomyxoma and transplantation. Unfortunately, he succumbed to what's called as graft-versus-host disease, a common phenomenon after multi-organ transplants. This is something that we face on a very frequent basis, not as much as the bone marrow transplant people, but we do face that because, as you know, the gut's got a lot of immune cells, and these immune cells can come up and attack the host and cause a variety of problems. 10 years ago, we had no treatment for graft-versus-host disease except for using a high-dose amount of steroids. 10 years hence, fortunately, we've got different cellular therapies that are used in the U.S. That helped our patient in the U.S. get over graft-versus-host disease. So unfortunately, the first patient died of graft-versus-host disease about 3.5 months after the transplant. Transplant was absolutely fine, working well. The second patient had a bleeding mycotic aneurysm. When I say mycotic, this is a fungal infection of the blood vessel that leads up to the graft. When I say graft, it is the transplanted organs. They require a blood supply. This is a blood supply that we create from the patient's own native blood supply. We create a channel that feeds into the transplanted organ. One of them had recurrence of disease. This would not be classified as recurrence. This would be progression of disease. As my next statement goes, the amount of recurrence that was there were 4 people that had radiological recurrence of disease, but all 4 were living with the disease and were asymptomatic. We could see the disease on CT scan, but there was not any reflection on their CEA and the CEA 19-9s. But we could see it on CT scan, but it remained stable. The reason they remained stable, I think, is because we switched our immunosuppression from a Prograf or tacrolimus-based immunosuppression to a everolimus and sirolimus-based immunosuppression within 6 months after the transplant. The recurrence or progression of disease that caused death was patient number 4 that had a pleural disease at the time of transplantation, and we at that point did not minimal pleural disease at that point. She went on for 6.5 years, and the disease in the chest grew to a certain extent, but she did not want any more treatment. She had the pleasure of seeing her kids go through college, and she was not interested in any more surgical therapy and succumbed to the disease. So our patient graft survival is 76%. All the remaining survivors are off TPN and thriving. We have the Cleveland Clinic experience here. I did the first multivisceral. When I say multivisceral, this is a true multivisceral that includes the liver graft with the abdominal organs, the liver, the stomach, pancreatic complex, small bowel, a piece of the large bowel, and a transplanted spleen too. This is a 32-year-old male with inoperable PMP and liver involvement, referred by the Mayo Clinic, and there's no other conventional options available. Now, this is the key point here. This transplantation or transplant oncology is a new field in transplantation. We are being very conservative in terms of our approach to this this pathology. We want to be absolutely sure that there's no other conventional means that the patient has already been exposed to and has failed those conventional means before they come to us. So he was transplanted to Cleveland Clinic in 2020. He's alive and well and doing well to date. So a few pictures here. This is our first case. You can see widespread pseudomyxoma peritoni, and unfortunately had a fungating tumor para his ileostomy. So he had multiple hypex and cytoreductive therapy, and then was deemed unresectable and developed this this mass around his ileostomy. I'm sorry about these pictures. I wasn't aware that the audience would be a variety of the audience and not only the medical field. Here's again another picture showing the amount of disease. You can see on the right side that you can see a tumor infiltrating through his ileostomy. Large volume mucin. And this is our preparation for his surgery. You can see the disease on the right side. The abdominal wall is all red, and so that had to be excised. And we got our plastic surgery team involved. This is, as I'd heard before, a multidisciplinary operation. You have people in colorectal surgery, you have people in plastic surgery, and the transplant surgeons, and sometimes urology. If there's any bladder and ureteral involvement, all coming together at one time. Those who are squeamish can close their eyes. This is the amount of resection that we can do. You can see on the left side is towards the liver. You can see the blood vessels of the liver is preserved as hepatic artery. The portal veins have been stapled off, and you can see the whole descending aorta and the IVC and clearance of the disease and the left kidney and the right kidney in place. This is the hole that we created, unfortunately, because we needed to be able to cut out the tumor that had perforated through the abdominal wall and had affected the abdominal wall. And this is the end result with replacement of the abdominal wall with an abdominal wall transplant. And of course, we also replace the intra-abdominal organs, which can't be seen right now. But this was the final product. So in summary, I think transplantation may be a valid option for patients with PMP, but you've got to be very strict to begin with. Those that fail conventional therapy and present very late in the clinical picture where there's not much that can be done. We know that medium and long-term results are encouraging. We are still in the phase of looking at low-grade tumors. In the Cleveland Clinic, for example, now we've got a algorithm based on patients that referred. That we refer them to our appropriate tumor board, depending upon what's the origin of the PMP. Right now, it's appendiceal, so it goes to the colorectal tumor board. The essential answer we're looking for in the colorectal tumor board is there anything else that can be done for this patient? If the answer is no, that's when we start the transplant evaluation. Transplant evaluation is based on, is it safe to do? Is it, second question to answer, is it feasible? And third question, is it going to be beneficial to the patient? So that's all the tests, transplant evaluation tests are based around these three questions. It's a recent addition to our repertoire, and there are a few publications. The most important publication, the last one, that is now on the desk of the Annals of Surgery. Thank you very much indeed.
Dr. V, thank you so much for that update. And I guess I don't know how the audience felt about the pictures, but I know all the surgeons in the room were impressed. Those are things that you just don't see every day. So thank you for your pioneering efforts in this area to bring another option to people who really don't have, are really at the end of the conventional option. So we look forward, we have some questions that we'll definitely ask you at the Q&A, and so we look forward to that. The next up is our very own Dr. Kiran Taraga. And Dr. Taraga is well known to the audience, but he is a practicing surgical oncologist with an interest in metastatic cancer and is currently the chief of surgical oncology at the Yale School of Medicine and the assistant director of the clinical trials. Is that CTO? Yep. And he was previously the vice chair of general surgery and surgical oncology at the University of Chicago. His interest in peritoneal surface malignancy has led to the establishment of now I'm going to be his second large peritoneal surface malignancy program, as well as he was really instrumental in spearheading the effort with the Chicago Consensus Guidelines, which are truly the only guidelines that we have in oncology for the management of peritoneal-based disease. And he's going to talk to us today about the implications of ongoing research in the treatment of appendix cancer. Dr. Taraga.
Thank you so much, Dr. Lambert, and it's really nice to see all of you. And thanks again to the ACPMP for putting together another wonderful symposium. I think for all the patients and caregivers today, I hope you learn a lot. But I think also feel free to use these opportunities to reach out to us, the ACPMP, about further questions and things that come up. So I don't have any disclosures, and I think this talk today is something that I'd like to provide a flavor for things that are ongoing in the field of cancer research in general, not specifically to appendix cancer, but something that all of us are interested in applying this. And I think it's important for patients and caregivers to also be engaged in these areas, because advocacy for these types of research is very important. The ACPMP has supported numerous efforts through this, but I think it's important even on a global level for all of us to support them. So the four big components of things that I'm going to talk about are the microbiome, diet, what do you think about precision oncology, and then maybe some tips and tricks for looking for clinical trials. Because I think, as you've heard, there's lots of new experiences, new treatments that are being tried for appendix disease. And how do you actually navigate the space? How do you find the clinical trial that's the best for you or your loved one? So I think when you think about the microbiome, I think it's very easy for all of us to want to have one culprit. Many times patients will come to our clinics and say, what caused my cancer? Why did I get this cancer? And how do we treat it? And many times we think unidimensionally. And you heard through Dr. Botanopoulos' talk on how, tumors are very heterogeneous, which means they occur in an environment which is very complicated. And one of those factors that makes it complicated is the microbiome. So we know that there's numerous bacteria and now even fungi that can actually contribute to either the development of cancer, or it can actually lead to the reduction of cancer development. So you can see there's different cancers that have either been associated with an increase from certain types of bacteria or a decrease from certain types of bacteria. One of the big bacteria that are being implicated in lower GI cancers, including the appendix cancer, is Fusobacterium. So it's a very interesting bacteria that resides in our gut that has been associated with some of these cancers. And so where is microbial research today? Well, microbial research is present in several ways. So firstly, it's being used as a treatment in itself. So can you actually use microbial treatments such as lactobacillus or enterococcus to attack cancers directly? And when I'm talking microbes, this is not viruses. I'll talk about viruses in a minute as well. But can these treatments also synergize with immunotherapies? You heard about immunotherapies such as PD-1 or PD-L1, sort of the checkpoint, the thing that prevents cancer cells from attacking normal tissues, but also or T cells or your immune cells from attacking normal tissues, but also prevents it from attacking cancers. Can these bacteria synergize with these new medications that will release that trigger called anti-PD-1 or PD-L1? Secondly, these can be used as biomarkers. You know, we worry a lot about how are we going to identify patients that are either at risk for getting cancer or those patients that have cancer, and how are they responding to treatment. And certainly studying the stool of patients as well as the blood of patients with biomarkers from these bacteria have been shown in numerous studies to have some value. I think clearly they are risk factors for treatments. And then clearly there's potential for changing the normal microbiome. And there's lots of clinical trials that are ongoing with bifidobacterium, one of the common bacteria found in yogurts, to look and see if it synergizes with therapies. So, you know, these are some simple experiments, and you'll find many, many other experiments like this, but this is one of the experiments where mice had resection of their lower GI tract, in this case the lower colon. They had it cut and they had a type of bacteria placed inside, and when the bacteria was reintroduced in addition to cancer cells, it caused the cancer to come back. And the interesting thing is, when the cancer comes back, it comes back in a location that leads to peritoneal metastases or spreading along the lining of the belly, which is what we see in a lot of patients with appendix cancer. The other thing that was very remarkable, and that's sort of in this graph on C over here, is that when the mice were fed a Western diet, so a high-fat diet, and had the bacteria in place. So now again, coming to this multifactorial model of carcinogenesis, the development of cancer, and especially cancer along the peritoneum, which is sort of over here in this graph on E, is really where these cancers started to develop. So I think just very intriguing questions about where the microbiome may be involved in this. A word of caution though, you know, there's a lot of players that would talk about using probiotics or getting a microbiome panel, looking at these things. I think these are all yet investigational. Hopefully we'll have some answers soon. But please be careful before you start doing this, and make sure you talk to your treating team before you do that. I think one thing which is quite simple and has been shown to work well is eating healthy vegetables and fruits that I think your treating team will talk to you about. So the next thing that all of us wonder about is diet. And I think one aspect of research that is really exciting is the field of metabolomics, where a lot of researchers are trying to understand what feeds cancers. Many of our patients will come asking, you know, I've stopped eating refined sugars because we've heard that sugar feeds cancer. And the answer is not that simple. We do know that cancers use different sort of substrates, which means they eat slightly different foods, and they have certain different pathways. They don't use the normal pathways of burning sugars like oxidative phosphorylation, but they can use different pathways in terms of getting their food. But what some labs have found, and this is one of the labs at the University of Chicago that found this, was that for development of peritoneal metastases, so for the development of cancers that go to the lining of the belly, one of the factors that was very necessary was fat, which was present in the omentum. And fat, which is present in the omentum and through adipocytes, provided the energy that these cancer cells needed. And the answer doesn't mean that we should stop eating fat, But what it did lead to is finding of some proteins and gene binding domains where with editing, you could actually change the way these cancer cells proliferate and grow, in this specific case, FAP-B4. And we also know that around the period of surgery, that the amount of fat consumption can clearly affect your surgical outcomes. This is a paper looking at the consumption of dietary fat. And when the dietary fat was high, patients had worse outcomes from liver surgery. And so just kind of thinking about, altering your diets around the period of surgery, and certainly as you're going through chemotherapy or surgical treatments. Again, I would say this is something you have to discuss with your treating team, but keeping your finger on the pulse for this type of research, I think is very exciting. The one concept, and you've heard this through the day today, that I did want to emphasize for those of you in the audience who may not have heard these terms before, but we are heading to an era of precision oncology. And the precision indicates that we're targeting with greater and greater accuracy the tumors, and getting more and more specific to the tumor cells themselves. And so chemotherapy, which is at the top of this slide, is sort of like the blanket. It treats most cells that are dividing, and so that's why people can lose hair, they can have change of taste, because these are normal cells that are also dividing, and that's why you see these effects. As opposed to hormone therapies, which are much more specific to cells that have hormones on them. And epigenetic modifiers are cells that are these agents that are actually changing the way DNA is wrapped, and these molecules and proteins that actually cause this wrapping to happen, or the activation of genes. Coming down to the immune checkpoint inhibitors, many of you have heard of bevacizumab or Avastin, which is a specific antibody that targets a certain type of protein, the vascular endothelial growth factor. But then coming down further and further to where you have some of the immunotherapies, which are vaccines and adoptive immunotherapy, and then finally two signaling molecules. So when you think about things like KRAS G12C, or you think about different sort of ways in which cancers are proliferating to block those specific signals. One of the factors that most of our patients will see, and you should certainly be aware of, this is something that most patients will have a conversation with their oncologists or surgical oncologists about, is gene testing. You heard Dr. Levine talk about Foundation or Caris. There's numerous companies that do this type of gene testing. It can be done either on the tissue, which means it's looking at the mutations that occurred in the cancer cells themselves, which led to this proliferation of the cancer. That's called somatic mutations. And those can be targeted with some of these precision oncology drugs. But as you heard, there are not those many precision oncology drugs that are available for most of the mutations we see in patients with appendix cancer. But what is also interesting is the concept of germline testing, where patients with appendix cancer will often ask, what is the risk of our family members? And oftentimes this is the gene testing that needs to be done to look for that. We tried a program where we almost routinely tested our patients for germline testing. We've had some very interesting findings for patients with appendix cancer with the germline testing. And we did find some variants. It's difficult to know exactly what that implication will be, but I think it's an evolving field for patients with appendix cancer. One of the biggest concerns we all have is, how do we detect these cancers properly? There's always a debate about whether we should do CT scans or MRIs or PET scans. And the reason we all struggle with this is because these cancers that spread along the lining are very difficult to detect. And so increasingly, there's concepts of using biomarkers, there's concepts of measuring DNA in the plasma to help identify these tumors and then develop treatments for this. You heard some of the talks earlier today that looked at this, but the concept of not thinking about a tumor as appendix cancer, colon cancer, breast cancer, lung cancer, but thinking more about it in terms of its biomarkers, in terms of its gene mutations. Can you actually think about a treatment specific for the gene mutation or the fusion, as opposed to thinking of it as an appendix cancer clinical trial? And so it's very important to think about that, and as patients, for you to be aware of the fact that some clinical trials or some treatment options may not be specific to appendix cancer, but may be specific to the type of cancer that you or your loved one has. And then I think lots of evolving research, lots of presentations this year coming up at our society meetings are focused on looking at cell-free DNA or measuring DNA in the blood to identify cancers early. And there's different parts of DNA that is shed by cancers. There are two big concepts. One is called circulating tumor DNA. Some of you might have had Signatera or Natera. That basically looks at mutations that were present in your tumor and then measures those mutations specifically in the blood. And then the other is cell-free DNA, which actually just measures any variant mutations that are in the blood and tries to identify that. And so there's many different ways of looking at that, but certainly becoming more and more common in patients with peritoneal disease, especially when we struggle to find this. You heard about immunotherapies already. I think two immunotherapies that you may have heard a little bit less of is oncolytic viruses and adoptive cell therapy. And so just briefly, oncolytic viruses are viruses like the herpes simplex virus that can actually directly kill cancer cells. There is a clinical trial that used viruses inside the abdomen for patients with appendix cancer. It causes these tumors to die, but also releases these antigens that then lets other immune cells come and kill it. It's a very interesting concept. There's many trials actually ongoing right now looking at oncolytic viruses. And then the other treatment is adoptive cell therapy, where we prime the immune cells, such as T cells, and put them back inside the body in different ways to help fight the cancers. And so some interesting concepts which is happening right now is just like we would get medications and you just have a pharmacy that prescribes them, now you can actually get what we call CRISPR edited T cells. This is also a version of CAR T cells for those of you that have heard this term, but looking at sort of these fighter cells called T cells, changing the genes that were specific to the tumor, putting it in a prepackaged sort of a T cell bag, and then putting it back to the patient. So I think sort of a much more faster way of getting these treatments back to our patients. So I think one of the advice that I did want to share with all of you is to make sure that if you do get any kind of testing done, make sure you're very aware of it, whether it's somatic, whether it's germline. Make sure that you track with your physicians and your treating team the role of any ctDNA, cfDNA, precision oncology, but most importantly, stay connected to groups such as ACPMP so that you can stay aware of the latest advances, because the field is certainly moving very fast, and that's great for all of us, but I think sometimes keeping up becomes harder and harder. And then finally, in the last couple of minutes, I would just say that, when you're looking for clinical trials, the sort of most comprehensive source of clinical trials is clinicaltrials.gov. Remember, you can search for clinicaltrials.gov in two different ways. One way is by searching for appendix cancer, and you can certainly look at appendix cancer clinical trials, and that could give you clinical trials in the US, across the world. But you can also look for clinical trials that specifically focus on the mutations that you or your loved one has. So I think it's important to kind of be aware of that. You always want to keep that in mind, and they're called targeted trials, personalized trials, precision medicine trials. And so I think it's an important concept to keep in mind. Patients do well when they do get personalized treatments with lower GI cancers. So I think, finally, I would just say, trust in your team. Make sure you talk to your physician team, your healthcare providers, your folks that you're working with, and certainly reach out and connect to communities as you're navigating treatments for yourselves or your loved ones. So with that, I thank you for your attention and look forward to the Q&A later today.
Great. Thank you very much, Dr. Charaga, and for all the panelists. And it was a great session. A lot, like you said, information overload for sure. But let's get to some of the questions that came through the Q&A. So this one's for Dr. Vatanopoulos. Do you know what % of the organoids are made up of cancer cells compared to immune fibroblasts or other cell types that also reside within the organoids?
Yeah, this is it depends on the type of tumor, because we don't sort the cells. So whatever the tumor has, every tumor has other concentration of fibroblasts, other concentration of tumor cells, and other concentration of immune cells. If we decide not to sort the tumor, we're going to use whatever the tumor is made of. But what we can do is we can come back later and stain it and see exactly how much of that is tumor, how much of that is fibroblast, and how much is the immune system. I can tell you right now that the immune system, if you don't introduce immune system, there is nothing there. Fibroblasts probably it's about 10-20%. And the other thing is we don't rely on we concentrate the cells. So we introduce in the organoid 200,000 cells. So the low-grade appendiceal cancers, as you realize, are like very acellular. To create an organoid, we concentrate the cells and we place them within the same structure.
Great, thank you. The next question in the Q&A, I think we'll either give this either to you, Dr. Vatanopoulos, or to you, Dr. Levine, because it was your research that's relevant to this. In the case of the second CRS HIPEC surgery, should the surgeon use mitomycin C again, if that was what it was used? And what is the time interval recommended between two CRS HIPEC surgeries?
Very good question. I think there's several aspects to that. The first one is, what's the clinical scenario? Is it low-grade cancer? Is it high-grade cancer? What other treatment has been administered? So to just come up with a blanket statement about what you do in every case, I think is not appropriate. So in terms of the specific question, should you use mitomycin or oxaliplatin? We just published a paper on that actually in the last few months. And what we found is it doesn't seem to make a whole lot of difference. They seem to be relatively equivalent in terms of what you can do, which is the same as I found in the randomized trial, that if you're going to perfuse, the efficacy of oxaliplatin and mitomycin are essentially the same.
And the research we did in the organoids actually verifies that either oxaliplatin or mitomycin C have the same efficacy at the cohort level. The only difference is that mitomycin C will, can function only also without heat. And at the end of the day, think about that. You have what is the role of changing that from one drug to the other? If you operate on and do a repeat HIPEC, probably the recurrence is going to be years later. I don't think that it really makes a difference of selection-wise in terms of resistant clones.
Great. Good to know. Dr. Tarago, what does the most compelling quality research say about intermittent fasting around traditional therapy? Do you have any information on that?
I think it's an evolving space. There's big papers that were published looking at intermittent fasting with regards to outcomes. Clearly, patients that were on pathways that did intermittent fasting were able to lose more weight, had better health benefits. There's a lot of research ongoing about how reducing obesity leads to reduced cancer risk. Whether that's specifically involved in appendix cancer or not, that's interesting. When we looked in the lab and we gave patients with appendix cancer glucose, and we tried to see how they metabolize the glucose, these cancer cells metabolize glucose very differently than, say, normal peritoneum does or normal other tissues do. And the differences are not very similar to other cancers like colon cancer, ovarian cancer. So it's a very different pathway of metabolism. And so we don't know if intermittent fasting necessarily makes a difference. There's some very interesting research on, keto diets, or sort of creating that, starvation sort of an environment to have anti-cancer effects. But my recommendation to all of you listening, though, is to make sure that you're working with your own teams, because, most of these teams have been doing this for many, many years. And, until the evidence is strong, be very careful on embarking on some, trial of, food or starvation that can actually hamper your cancer care.
Great. Yeah, very sound advice. Dr. Vaidya, question for you. Any role, or do you foresee any role for transplant in higher grade tumors? And actually a question that I have, how difficult are you, with the system that we have for organ donation and procurement in this country. What challenges are you facing specific to the US compared to the UK with regard to starting the program here?
So let me answer your first question, is high-grade tumors and whether they benefit from transplantation. We don't know. That's a very clear answer. We've started with low-grade tumors, and I think as an evolution, we will progress to high-grade tumors. And that has to be done under an IRB, and it has to be done under a very regulated environment to see whether there's any benefit to the people with the high grade, and is there any survival benefit to them. So that's clearly that's the answer to the first part. And the second part is a bit more tricky. If you're doing perhaps 1,000 cases a year, then yes, of course, you're going to have an impact, and people are going to wonder, what the hell are you guys doing? You're taking you're taking livers away from people who've got liver failure, rather than you're taking livers away just because anatomically, and for tumor clearance, you need the liver in the graft, right? So those are very ethical questions that are going to be asked in the road downstream. However, right now, we're looking at a very small cohort of people who qualify for transplantation, who've failed all conventional therapy, and therefore we're not yet on the radar, creating problems for UNOS or creating problems for organ allocation as such. Mm-hmm. Most of the cases we can get away get away without the liver. So that's where the constraints are. There are not many patients out there for stomach transplants or pancreatic transplants or intestinal transplants, really. So we're not competing as of now. So that isn't an issue as of yet.
Mm-hmm. Great. Well, again, good luck to you in this effort. Dr. Levine, back to you. A couple of questions about BROMAC. Any insight as to whether it's useful for addressing high-grade tumors? And finally, is there anything that the patients can do to advocate for FDA approval in the US?
I think we've got some new information. Actually, Dr. Botanopoulos just finished a work looking at the effect of the bromelain on organoids and cell cultures. You want to talk about that?
Well, we cannot really disclose this data yet, but bromelain does have an action against a variety of cells. It's an enzyme, right? Well, give it a couple of months. We're going to present this data soon.
In terms of the other question, can you talk to somebody and lobby to get the FDA to do the right thing?
Yeah.
If you know a senator personally and you can move the ball, I'd certainly appreciate it. So would our other patients. One thing I wanted to say in terms of the transfer, I happen to know I've been in contact with one of the patients who's a survivor from the Oxford experience, who's actually on the session today, who was voted to join us and sends his regards.
That's terrific. Great.
Oh, wow. Is Adam?
I'm probably not supposed to say, but I wouldn't be surprised if it was.
Well, there you go. Hey, Dr. Charaga, somebody wrote in that she was diagnosed with appendiceal cancer in May of this year and found out that her second cousin was diagnosed with appendiceal cancer several years back. What's your experience with this running in families?
Yeah, and I think this is something that I'm sure, I'd love your opinions as well, Laura and Ed's. In some of our germline testing that we've done, we've actually seen BRCA2 mutations, we've seen CHEK2 mutations, and we've had one more familial mutation. The problem is it's hard to know if these are true variants. So in response to your question, I would say it's certainly worthwhile to talk to, obviously both your team as well as maybe a genetic counselor. It's very rare. So far, I don't think we've found a very clear underpinning of genetic sort of familial traits that lead to appendix cancer. But I think as our testing has gotten better, I do think we'll uncover some associations, but I don't think we have the data to be prime time yet.
Yeah. I know in my experience, I may have encountered one person who had like a very close relative who I was told had appendix cancer, but I could never confirm it, and so it's hard to know. And I obviously don't. When I get asked that question in clinic, my answer is a little bit tongue in cheek, but I say I wish it did run in families, because then we could identify a group of people who are at high risk for developing appendix cancer. And I'm sure everybody on here would love to do like a whole day of just prophylactic appendectomies. What a great day with an intern, do like 10 of those in one day, and prevent cancer. But I'm sure we will learn more as we do more genomic testing on the tumors. But as of right now, I don't know of any familial inheritance as well. Ed Costas?
We have in our database one father-son combination, but we haven't found any specific gene that's related to it. It could just be a random event, and one which are uncle and nephew, and that's in 1,000 patients, and that could just be random events. So I'd love to tell you that we have some proof. We haven't found a genetic predisposition either.
Mm-hmm. Yeah.
Well, I also have like two siblings who had appendiceal cancer, but I would say that I recently reviewed some very interesting data that again I cannot disclose, and just give it some time. I think some very interesting data will be coming out by extremely prolific researchers.
Excellent. Well, look forward.
Costas, you got to stop doing that. Giving those little tidbits of information.
I mean, this is what comes. I'm sorry for the disaster, right? I mean, like
This is what comes of being a reviewer for the different journals.
Exactly. Yeah. Does anybody know about the role of CAR T therapy for appendix cancer? Ed, I think you had commented on that once.
Right. I mean, I think it's theoretically possible. I don't think we have the antigens. And Dr. Taraga talked a little bit about this in his talk a few minutes ago. I wish we had the ability to do that. I think it's on the drawing board. I don't think we're ready. Karen, do you have any other information for CAR T?
Yeah, I mean, I think there's phase 1 clinical trials for CAR T intravenously. Of course, there's the injectable CAR T for mesothelin, but there's also different targets for CAR Ts that are in phase 1 trials right now. So I think for all the patients on the call, I would say not quite prime time yet, but certainly could show some promise. Like what Dr. Levine was referring to, we don't have unique signatures to the cells themselves that we could target and program these T cells to go attack. And so I think that's the challenge. If we had that, then I think it's more likely that CAR T cells could be successful.
Yeah, I echo that.
Mm-hmm. Yep. Dr. Levine, another question specifically for you. There's somebody who's interested in a trial that you are a PI on, and I'm not going to say this right, evaluating pegcetacyanine.
Right. So this is actually a novel imaging agent, which is done by a handful of centers to do HIPEX, and it's an injectable agent which looks at the pH of the cells, and under the right light of the right wavelength, it'll actually fluoresce. So we can inject the patient a couple of days ahead of time and do the operation. Once we finish the conventional operation and shine the light and see if there's any additional tumor that you can see with the enhancement with the imaging agent that you could not see with the naked eye. And this is essentially a phase 1-2 trial. We've treated, probably a dozen patients here. I think there's close to 30 patients on it nationwide. So is it a promising trial? Yes. Would I encourage people to enroll? It's a very safe imaging agent. We had one very minor allergic reaction. Somebody got Benadryl, they did fine. So the agent is actually quite safe as far as we can tell, at least in our early experience. What we don't have is the actual outcome data. Does it make a difference? Anecdotally, have we found some, because when we find these additional spots, we take them out, we send them for pathologic analysis. We've had a couple that actually showed something. So there are going to be some times where you can see things. Is this the perfect agent? No, but I think it's another one in a line of imaging agents, which may help what we can do looking as opposed to your eyes and your hands in the operating room, something to enhance our ability to detect particularly low volume disease.
Yeah. Yeah, that would be great. Anything that can help get a truly complete cytoreduction would be terrific. A question for the whole panel: what sort of gene testing do you recommend for a patient with Lambert who has had 2 cytoreduction and HIPEX prior to that? Do you guys have a preferred genomic testing for those tumors?
I don't think that the genomic testing at this setting will do will offer anything to the patient.
I mean, the experience, frankly, for appendiceal cancer, unless it's high grade, the yield is so low. Well, I don't think we've got a single patient we've tested who has a driver mutation we've been able to treat to good effect to date. High grade is a different thing. Carcinoid, if you have it, totally different thing. But these low grade tumors, the rate of actionable mutations is, you're looking at 1%, 0.5%. And even when you find it, we've had a few that we found it when you treat it, we haven't had a substantial response. I mean, I don't know if you have, but we've been frankly reasonably disappointed in it for appendix cancers. For other tumors, totally different. It's totally different for other tumor systems. It has not been this hasn't even been a bunt single for appendix cancers.
Yeah. Hopefully Dr. Flatmark's vaccine will get off the ground, right? Because the high rate of GNAS mutations, that's going to be something that potentially will be directly targetable for these tumors. So
a lot of people want to visit Norway. There's no
exactly. All of a sudden. Anybody familiar with the role of ivermectin, or I might say this wrong, quercetin, for treating cancer? I guess there's some NIH studies going on in that. I know ivermectin's been in the news a lot lately with COVID, but thoughts or comments on that?
The only study I've seen for ivermectin was negative, and I'm not familiar with the other agents.
Karen or Dr. Vaidya? No? Okay. I'm not familiar either. And then one last question here on the Q&A. Dr. Levine, any thoughts on Bromac treatment before cytoreduction and HIPEC, maybe to help spare organ removal?
Well, if we had the drug, we could try it. I think the concept is not crazy. Usually removing the mucin is not the problem with these operations. Mm-hmm. It's removing the tumor that's creating the mucin. That's the whole key. Again, for the people in the audience, the mucin is a byproduct. It's sort of analogous. So if somebody leaves your car running in the garage, the carbon monoxide will build up as a byproduct. The treatment is to open the garage door and turn off the car, right? The goal is to stop the production of the mucin. The only way to do that's going to be to resect the tumor pretty much.
Yeah.
I do think, if I could make one comment, it is exciting that we have, numerous clinical trials. We have Dr. Vaidya here and Dr. Rauf, and then of course our own Dr. Levine. We've been doing this for many years. I'm sure Dr. Lambert would agree with me, but it's nice to finally be in a space where there are numerous clinical trials and sort of newer options that are coming through for our patients here. So I think, I will certainly say that the ACPMP plays a big part in getting many of these research efforts up and running.
Absolutely. And we welcome Dr. Rauf. So if there are any last minute questions about PIPEC, we tried to answer them on your behalf, Dr. Rauf. But there's one more question for Dr. Taraga. Maybe you could speak to iterative HIPECs and places where they're being offered.
Yeah, so I think conceptually, the iterative HIPEC was our version, a little bit of PIPEC. We took this concept from the MD Anderson group for gastric cancer, and we found that the repetitive application of chemotherapy in an unresectable setting would change the immune phenotype of these cancers. And so we thought it may be worthwhile to try that in appendix cancer patients, which is what we published our first set of patients on. Logistically, it's very straightforward to do the iterative HIPECs. We do it every 6 weeks apart with intervening chemotherapy in between. We've seen some very good responses. I don't think it's curative. I think in concept it's very similar to PIPEC, and it's easier and you don't have to go through the regulatory hoops that you have for PIPAC. But I think it's worked well. I think it's just a question of, formally studying it in a bigger multi-center way.
Yeah. Thank you. And so, Dr. Rauf, there were two questions earlier about specifically for PIPAC. One was if the PIPAC can be successful on high-grade hardened tumors like goblet cells. And then the other question was about the risk of adhesions and how significant do you think that is, and will it preclude people from getting additional surgery in the future?
Yeah, both really great questions. So, so far, in the first trial that I presented, we treated 4 patients with appendiceal cancer. 3 of those were high grade, and I think 1 of them was goblet cell phenotype. So, I think we need to treat more patients to be able to say if there's any effect. So far, we can say that the way we're doing it right now, it's safe. How do we prove the effect? That is actually a really challenging question, and it's not limited to PIPAC. It's also a question of iterative HIPAC. How do you measure response? And that's kind of the struggle we have right now in the field, is figuring out how to say a therapy meets a certain benchmark. And we can go by previous overall survival, which is like the gold standard, but it has its limitations because many other things can impact survival. So for goblet cell, I think it's going to be a difficult trial to do just focused on goblet cell cancer, but to prove efficacy, we need to gather all the patients that we can and measure that effectiveness benchmark to prove that. Adhesions. So we've seen. Probably after the 3rd PIPAC is when people start developing a lot more adhesions, and it's hard to know in advanced disease how much of those are tumor adhesions versus an effect of treatment. And I think it's a bit of both, to be honest. And so yes, eventually, if you continue to do intraperitoneal therapy with HIPAC or PIPAC or normothermic intraperitoneal therapy, you will form enough adhesions that will preclude further intraperitoneal treatment. And sometimes that can be a good thing in the fact that tumors have melted away and now it's all scar, but other times it could be a sign of disease progression.
Right, and yeah, I agree. Well, I think the more experience we have with PIPAC, we'll get to better understand the impact on the peritoneal cavity from a surgical perspective as well. So,
yeah.
All right.
Dr. Lambert, can I ask a question?
Yes.
Is there anyone in the US that's doing thoracic HIPAC? So almost like the same thing that's done in the peritoneal cavity, but for the thoracic cavity. In the UK, yes, they are. The question is that something that people are doing in the US? Because I do see patients who've got some pleural disease, and technically that would be they still got low grade PMP in the abdomen, which I can clear. But since we were adhering to our principles of disease located or restricted in the abdominal cavity, these people are not considered for transplant, so to speak. So in the UK, we started the whole thoracic PMP and HITOC, high intensity thoracic chemotherapy. Is there any experience in the US as such?
Yes, absolutely. I know the different programs, the high volume centers have done it as indicated, I think primarily for GI tumors. I don't know if anybody's doing it for pleural mesothelioma, but Dr. Taraga, Dr. Levine, Dr. Vatanopoulos, Dr. Rauf, your experience with it?
We use it selectively. Occasionally we'll do it. The difference in the chest is that if you can get, if you do a pleurectomy, once you get the parietal visceral pleura, the parietal pleura the visceral pleura to stick to the chest wall, it'll wall things off and hold things off for a prolonged period. So can you? Yes. Do we do it frequently? No. And unfortunately, frequently is going to go with some relatively substantial pulmonary resection. It's not always easy to get it off of the visceral pleura.
You have to see how much disease you have in the abdomen. So to go, it's very rare to have like a separate disease in the chest without having, enough disease in the abdomen. And then you go to the situation.
Sorry.
You go to the situation and you start questioning as if, what are you achieving by removing the disease in the chest when you are leaving volume of disease in the abdomen?
So right, exactly what I'm saying is that when patients are being considered for abdominal transplantation, as the certain clearance of disease in the abdomen, but they still have some pleural disease that's not been addressed. And would it be like a stepwise progression where you get your pleural disease controlled with thoracic interventions, and then come back to me and then I transplant and take away the abdominal disease?
Right. So essentially, we describe a situation that the patient is candidate for transplantation, and you have to remove the thoracic component first.
Yes. Yes.
I think it's going to be a very small group of patients that would go for that.
Absolutely. I mean, I don't think there's going to be a mass influx of patients for that, but there's going to be a small cohort that perhaps do not qualify for an abdominal operation because they've got thoracic disease. You see.
Mm-hmm.
Yeah.
Already pushing the boundaries even further. I think this was a really good session, really good questions. Again, bringing hope. I think, again, as Dr. Taraga mentioned, all as we've looked back on previous symposiums, it's incredible to see the depth and breadth of research that's being done and where things are going and the increased number of options that we now have to treat people. It's just a very exciting time to be a part of this field and treating and taking care of people with appendix cancer. So thank you very much, everybody, for your participation, and we look forward to the next session.